I'm just very concerned about reopening the borders too generally to international travelers because, as we're seeing just in the last 2 to 3 weeks in Europe, with rates going up significantly, why is that happening?
Welcome to the RANE Insights on COVID-19 podcast. I'm Emily Donahue. Let's listen as RANE founder David Lawrence speaks with Drs. Fred Southwick and Bill Lang for our weekly coronavirus update.
Bill, Fred, thanks again for joining us. We're going to look at a 20-minute update in the landscape of the data, vaccine rollout, et cetera. A lot of data coming from Israel. Dr. Fauci and others have focused on it in terms of the advisability of boosters for all. Maybe we can just start there and would like to address the pediatric booster. And Fred, I know you're doing some incredible work and have some insights in terms of the long-term complications from for people who have had to be admitted to the ICUs. So why don't we start with data from around the world, specifically Israel, and this notion of eventually boosters for all.
Well, certainly the biggest thing with the Israel experience is that, as everybody knows, Israel was the earliest and the biggest push for vaccination. And they got to the point of vaccinating about 75% of the nation fully vaccinated, another 5 to 10% that are partially vaccinated. And then there is a hardcore, primarily Orthodox population that is not getting vaccinated. But they still have roughly 75% of the population fully vaccinated. Despite that, over the summer, they had a huge resurgence in disease. This was Delta was responsible for it. But what they did was they moved rapidly on instituting a booster program, and they've boosted about 75% of those who were already vaccinated, and they've driven their rate of infection back down to almost zero. I mean, it rounds to zero, essentially. So boosters just in real life, taking the scientific process out of it, looking at it in real life, have worked.
Yeah, I think the booster makes really good sense, particularly when individuals are not effectively using their masks and are tired of social distancing. The real solution is to achieve herd immunity with vaccine. And that's what Israel is doing. And the argument is, well, we shouldn't focus on the boosters because we have too many people in the US and around the world that haven't gotten their first dose. So why are we focusing on those that have already had 2 doses? Well, the argument, I think, can be made that, yes, we've given 2 doses, but now, because of waning immunity, that's no longer effective. In order to continue to secure the advantages we got by vaccinating that population, they require a booster. So I'm in favor of a booster for most individuals. There's some argument also that the younger people, under age 30, they will get very mild disease. The only problem is they could then spread it to those that are more susceptible, older ages and immunocompromised. So I think everybody should receive a booster as their immunity wanes.
Yeah, and along those lines, I think more and more authorities are saying that the CDC guidance that on boosters should be given to people who are at high risk should be read very expansively. And especially when you look at the occupational indication for booster, which basically says anyone who has frequent contact with the public, that should be read very expansively. And the way I'm reading it is, so that basically means all people who have retail contact, people who fly frequently. Those are all people who have frequent contact with large numbers of people who you cannot verify their vaccination status. So to me, that qualifies people for getting boosted.
Great. Let me switch because the rollout has begun for vaccine for children. Any particular insights that you can share with the audience in terms of how that is going and just generally what the data is saying?
Well, the uptake is quick. It's only been about a week, and there's typically it's about running about 5% of kids that have been vaccinated, which is a pretty good uptake for just the first week. Most authorities believe that over 50% of children in the United States have already been infected with COVID. That's around 14 million. So we need to get. It's that other 50%, but oftentimes we don't know who that other 50% is. We think that the adverse event rate for the vaccine is about 10%, but there were zero significant adverse events in the study population. But unfortunately, that was only right around 2,200 kids. So you can't draw huge conclusions from it, other than we know there's no high rate of severe adverse events.
Yes, and one thing about that, the number of cases or number of children 5 to 11 that have been studied is relatively low, but there's little reason to believe that the complication rates are going to be anywhere are higher than those from 12 to 18. Where aside from myocarditis, there really have not been any significant side effects. And the good news is the dose that's being used is 1/3 of that for those 12 to 18. And so far, there have been no cases of myocarditis using that dose.
And in fact, in the older kid population, the cases of myocarditis have been in the older kids. So the 16 to 18 population has had significantly more myocarditis rate than in the 12 to 14-year-old population. So while you can't 100% draw a conclusion that it's going to be even lower in the younger kids population, there's reason to think that may be the case. The one thing we don't know is long-term effects. And that's what many people who are being resistant to vaccines keep saying is we don't know what these long-term effects of the vaccines may be. But on the other hand, we do know the potential for long-term effects of getting COVID. I mean, even in children, there are long-haul adults and there are long-haul children. We know that happens. We don't know that there are any long-term effects from the vaccine, and we know that the vaccine very, very effectively prevents disease. So we're preventing long-term effects with the vaccine, taking what is believed to be a very, very small risk of long-term vaccine-related effects.
The other thing to keep in mind, there have been over 8,000 admissions of pediatric cases to the hospital as a consequence of infections. And the other big concern, which is rare but is quite devastating, is MIS-C, that is Multisystem Inflammatory Syndrome in children. And that can cause very severe myocarditis to the point of some children have required cardiac transplant. So there are some very serious potential harm if you do get infected. And the vaccine, we know of no serious side effects so far in the vaccine. So the benefit to risk ratio is tremendous.
And just going back to just a few minutes ago, we were talking about the need to get to herd immunity. Remember, there is good evidence that with Delta, because it is so infectious, and if you do the epidemiology on it, we probably need to get somewhere near 90-ish% immune in some manner, whether that's through vaccine or through disease, to reach a effective herd immunity effects. We're not going to get there without kids. And so that's the other big piece of that, is trying to get these kids vaccinated and then getting the boosters, because not only do you have to have 90% that have had immunity at some point, you need to have 85 to 90% who are immune at the same time, because that's the way you're going to get the herd immunity effects.
Yeah, one other point that I've heard talked about is,
just switching
as Bill said, probably about somewhere 40 to 50% of children may already have been infected. But what you could do, and this has been recommended, is to do an Elisa assay to determine if the child has antibodies to the virus. If they do, then they will only require a single dose because you could assume the initial infection was your first shot, and then you would just receive the one shot. That would save a lot of vaccine. The only issue is how easy it is to get the Elisa assay and get that result back quickly.
That also brings up the issue of the effectiveness of natural immunity versus vaccine-induced immunity. The official position of CDC is that vaccine-induced immunity is much better than natural immunity. But there are a number of studies out there, especially studies out of Israel, very large studies, tens of thousands of people out of Israel, that are demonstrating that you have higher and more durable resistance if you got natural disease rather than getting the vaccine. The problem is that there's still a large number of people who get infected who don't develop good immunity, and you don't know who's in which group. It's not just simply a function of how sick were they, and even then, how do you grade how sick somebody was? So I think the CDC is taking a little too strong a position of totally ignoring whether or not someone's had infection before in determining what they need to have to be immune. But I think it's probably not quite as strong as the Israeli studies are showing. So I think we're somewhere in between.
So underscoring the efficacy and safety of the vaccine, there was an announcement this week about opening up the U.S. borders to international visitors, particularly important to cities such as New York that depend heavily on the travel industry and visitors coming here. And your thoughts in terms of returning to a more normal environment, and your thoughts not simply about people coming from around the world who've been vaccinated, but obviously thoughts about Americans who may, for purposes of business or pleasure, want to travel abroad.
I'm just very concerned about reopening the borders too generally to international travelers, because as we're seeing just in the last 2 to 3 weeks in Europe, with rates going up significantly, why is that happening? Part of it is the end of summer travel that was happening and bringing people traveling throughout Europe. We're going to now bring that to the United States. I think we should, and it's important to reopen to business travel. This is more opinion than anything. I think that opening it to travel in general, one big jump, I think is a little bit too much. Fortunately, it is with vaccination requirements, but we'll see what happens.
Yeah, Bill, I agree. The big mistake that has been made in the U.S. and many countries over and over again is to assume that the epidemic is over. And that's simply not the case. There's still, as one pediatrician stated, there's still plenty of wood to burn. And so we really have to be cautious and do things in a graded way rather than all or none. And I think that's very, very important. Somehow, it's not politically correct to gradually open anything up. You have to do it, completely open everything up, and then guess what? You get a rebound of infections. And I don't know how many times we have to do this before we learn, but it seems to be we have to do it over and over. And it's from someone who works in the hospital and sees the admissions. This is exceedingly frustrating to see the same mistake being made over and over again.
So relevant to your point about admissions, I know both of you are thinking about a number of levels of the pandemic, the lessons learned. New data is coming out, and with it some media coverage for the people who had to be admitted to the ICUs. And as you've pointed out, a vast majority of these individuals are people who have not been vaccinated, but the long-term consequences. And Bill, I think you stated that fortunately none of the patients you cover have had to be admitted to the ICU, but Fred, you're in a different vantage point by virtue of your position at a leading hospital. What can you share with the audience about some of these long-term consequences?
Well, when someone is intubated and has a ventilatory support, in order to efficiently ventilate them, you usually have to use low volume, high respiratory rate. This is a natural respiratory approach, and so patients would fight that if they're awake. Therefore, they have to be heavily sedated and often paralyzed. The problem with this sedation and paralysis is that all their muscles become weak and they get severely deconditioned to the point that many of them can barely move at all once they get off the respirator. And it requires months to actually recover physically, to actually move in the house normally. So what this means is they need a prolonged physical therapy. They may require a inpatient physical therapy unit to build up their strength. Unfortunately, a fair number of them never fully recover. And the other thing that we're hearing about, and this has been true of all intensive care unit admissions that require intubation and sedation, is many of them experience a cognitive impairment. They just feel in a fog and they never get back to normal. The other big problem sometimes that can happen, we are very cautious about this and our nurses are very good about it, but sometimes a patient can get a pressure ulcer from lying in one position too long, and these pressure ulcers can become very heavily infected and actually lead to sepsis subsequently. And there was a report actually in the New York Times today about a patient who actually suffered sepsis as a consequence of a large decubitus ulcer. So being hospitalized in the medical intensive care unit is extremely stressful and is too often leads to permanent disability.
Generally, Fred, the takeaway message is survive, you're discharged, but there are long-term consequences to COVID-19, which are just beginning to be understood.
Yes, that's exactly right. The other thing that we've noticed about patients who are in the intensive care unit for a prolonged period is their immune system becomes weakened. And so they're more susceptible to other infections in the future. So it's if you possibly can avoid being admitted to the medical intensive care unit, you should do it. And one of the best ways to prevent that is to get vaccinated.
Great. A couple minutes left. I'm going to turn back to you, Bill, just in terms, because we have questions from a number of our clients about, and we've addressed this before, but I think it's important, but from both you and Fred, whose data should we trust when we're trying to understand what's happening, where on a local level, where we have people, where we have property, where we have critical supply chains, etc. What's the best way to guide these, guide decisions?
Well, I think that what has become the guiding statistic in government and media has been the number of cases. I think we've talked over these sessions at length about how that's not a good statistic. You're better looking at hospitalizations or unfortunately even deaths, but that is the number that is being used and cited more often. But remember, as we get to the point where between the hospital management capabilities, the monoclonal antibody treatments, and now very soon to be the antiviral treatments of Merck and Pfizer oral antivirals. This is going to move more and more to a disease that does not lead with it high rates of hospitalizations or deaths. And if we still may have high numbers of cases, but if you're trying to manage and make decisions based on just on cases, when a case doesn't really have significant long-term implications, then you're going to be over managing. So you've got to really be watching hospitalizations and deaths. That will decrease with all of the treatments that we are bringing to bear, especially the new treatments that are coming online over the next probably 30 to 45 days. The one other issue that I think we just need to touch on very briefly is the emergency temporary standard and what its current status is. As we know, the emergency temporary standard was issued by OSHA, which essentially requires that by December 5th, anyone who is in a workplace of more than 100 people who is not vaccinated must wear a mask, and by November 4th, all companies must have in place a policy that requires either vaccination or testing for anyone who is not vaccinated. that was issued last week, and then on the end of last week, the Fifth Circuit Court of Appeals put a temporary stay of the emergency temporary standard into place. Now that has really confused a lot of people, because while there is a temporary stay in place nationwide, what happens if that stay is lifted? Does that mean you immediately go back to the pre-existing deadlines? Most authorities believe that if the stay is lifted, they will extend the deadlines by the number of days that the stay was in place. There's nothing hard and fast about that. It depends on whatever the order the court gives, but that is what is anticipated. So the take-home message on that for most organizations is keep getting things in place, because you don't want to be caught flat-footed if the emergency temporary standard is reinstated. But you're also you're probably not going to be required to comply instantaneously. You'll still have the 30 to 60 days as anticipated in the initial issuance of the temporary standard.
Bill, don't you anticipate that the mandate will eventually be supported, in that OSHA's role is to make the workplace safe, and having everyone vaccinated or being tested, and if test positive, not being allowed to go in the workplace, is the best way to keep workers safe.
Oh, without question. The issue is whether is on two grounds. One is it an emergency? And the fact that our rates have been coming down and stabilizing, and the fact that it took 4 months from the initial statement that there would be an emergency temporary standard until taking effect. Does that demonstrate that it is truly an emergency? So that's one of the issues. And then the other issue is the constitutional issue of control of disease has traditionally been a state level function. This is the reason why, including throughout the management of this, it hasn't been, CDC has given guidelines, but any enforceable orders have come from the states. So it's the police powers, to include police powers related to disease, are traditionally, and many say constitutionally, a state level function. So if a state wants to issue a mandate, there is no constitutional issue with that. The federal government issuing a mandate is a different story. But I'm not a lawyer. We'll leave that to David.
No, and you guys are not politicians, and of course, campaigns are being run on this point. So listen, Bill, Fred, once again, thank you for the insights. I know you guys are very, very busy, so really appreciate you making time for the audience and for sharing very, very valuable perspectives. I look forward to catching up with you guys next week. Just stay safe.
Thank you, David.
Thank you, David.
Dr. Bill Lang is an expert in public health responses to biological incidents, including pandemics. Dr. Fred Southwick is an infectious disease specialist at the University of Florida College of Medicine. Both doctors are part of the RANE Expert Network. Individuals and organizations turn to RANE for risk intelligence that cuts through the hype to focus on what they need to know, what to expect, and what to do. Sign up for our coronavirus solution and get critical information on the COVID-19 pandemic delivered daily. Visit us at ranenetwork.com. That's RANE network.com. I'm Emily Donahue. Thanks for listening.